I think there's a number of skills that people need to do well. The main components of med reconciliation are take an accurate medication history, to do good reconciliation at discharge, to counsel patients about their medications at the time of discharge, and then to make sure that information gets forwarded to their next provider of care. And there's some tips regarding taking medication histories that we've been working on a lot. For example, not reading a list out to a patient and asking them if it's right, but rather having the patient tell you what they're actually taking, and that way you know how well they understand their medications, and it's easier to figure out if there are discrepancies between what they think they should be taking and what you think they should be taking. I think there's a set of skills that you need to do this process well, and I think there are tools that you need and there's information sources that you need. Within those boundaries, I think there's a number of people who could, for example, take a medication history. Some places are using pharmacy technicians, some are using pharmacists, some use nurses, and some use physicians, either residents or attendings. And I think really depends on the resources you have at your hospital. At the end of the day, I would say it's the attending physician who has to take overall responsibility for it being right, because in the end, it's the orders written for that patient that we're responsible for, and MedRec is one way to make sure that those orders are correct, but a number of other people can do the job. Sometimes we suggest that places use pharmacists or pharmacy technicians in their highest risk patients, because they are probably the most skilled and usually are given the most time to do this well.